This is Dr. Isabella Meek from UnabridgedMD, and it's my pleasure to have with us Dr. George, Patricia. She is a very dear friend of mine and an incredible colleague of mine. She is a pulmonary specialist and particularly pulmonary hypertension specialist. She's the program director and the head of the Pulmonary Hypertension Section at National Jewish. She is going to talk to us about the program that she's created both at National Jewish as well as outside. She's created a team that's called Team Phenomenal Hope. So she'll talk more about this because I will ask her questions. And then the last thing is that she has a passion for teams to take on complex programs. And she is a very well-researched person. She does a ton of research. So when I say hope driven by science, she embodies that completely. So thank you so much for being here. It's so exciting. I'm so happy you're here. So, you know, I a couple of questions, and I hope they're not too hard. But as I mentioned earlier, the idea of UnabridgedMD is to bring hope to patients. And so maybe if you can start with telling us what pulmonary hypertension is for a layperson, and very short, because I'm sure you could go on for hours. And maybe if you can explain, you know, when patients come to you, say often that they are terrified and they are scared and come out of your clinic, and I see them, treat patient after you treat them, and they have a big smile on their face and they have hope. Can you start with this? I would love to hear you share this with us.
Yeah. So first off, Isabel, thank you so much for having me on your podcast. You know, I think so highly of you, and it's such a privilege to be able to talk with you about this really important topic that's near and dear to my heart as well. Hope is a very powerful energy and tool and tactic, and we'll get all into it. About pulmonary hypertension. So pulmonary hypertension, or what we say pH, means high blood pressure in the arteries of the lungs. And what I often talk about with people I see in clinic, high blood pressure is a super common disease, right? Regular high blood pressure, like when you go to the doctor's office, but having high blood pressure in the lungs is not very common. And there are different types of pulmonary hypertension, and some that are more common than others, and they're all treated different ways. It's a chronic disease, and typically, you know, when we talk about pulmonary arterial hypertension, it's known as a chronic disease and can be progressive. And people have to go on medications that they usually take for the rest of their life. So, as most people do, many people do in this day and age, before they come to the clinic to see the pH specialist, they hit the internet and do a web search. And oftentimes they come up with statistics from their web search, and they'll walk into clinic very stressed. They'll say, you know, they've come up with a reason for their symptoms, and they'll come up with a statistic. I often hear, I only have 3 years to live. But this is something that's out there when people search, but isn't true. So isn't necessarily true. So a lot of times I spend in that initial visit talking about, okay, what really is pulmonary hypertension? What's our approach? Like, let's come up with the actual diagnosis, the type that you have. I talk about how a lot of those statistics come from before we had the myriad of effective medical therapies that we have today. And we have a lot of clinical trials bringing new targeted therapies to us in the near future. So, you know, I try to dispel some of those fears, or at least assuage them, and try to help people get the actual, here's your diagnosis. You got to start with that. Mm-hmm. Sometimes we find out they don't have pH or PAH, and most of the time that's a good thing. You know, well, in people's minds, I should say. Sometimes you'll get people who they had a reason for how they're feeling, and now they're troubled because now we still don't know. So it's interesting to see people's walk, like their path, and there's no right or wrong path. It's how you experience trying to understand why you don't feel well, why you're short of breath. So that's a little bit about pulmonary hypertension and my broad approach when I first see people in the clinic.
Mm-hmm. That's very interesting. So I have to say, when we send patients from a rheumatology perspective, we send patients to your service, usually we are worried because it's usually associated with scleroderma. And when you have pulmonary hypertension and you have scleroderma, that's not as good as if you don't have pulmonary hypertension. So can you, so I think that that's actually a super important point. And I tell this to my patient as well, which is the studies are coming faster than the internet can catch them. And so we are always outdated when we're looking at internet. Can you tell us, in the last, how long have you done pulmonary hypertension? How long have you been specialized in this?
Yeah, so I finished my fellowship. I did 4 years. I did a fourth year. And I started out as a lung transplant doctor.
Oh,
So
wow.
that's a different hope. That was in 2008 when I finished fellowship. And then when I was doing lung transplant medicine, not surgery, I got more and more into helping people with pulmonary hypertension get to transplant. So that I've probably been, and then I got more into pre-transplant care of PH, and then fully now PH, and very little, I don't take care of transplant patients except on the odd now and again. And so I've been doing PH probably since 2010, 2011.
Okay, so let's say 10 years, about 10 years. So 10 years is not that long of a time for a person. However, I want to hear what has changed in 10 years in pulmonary hypertension, because I bet
a
lot has happened.
Very cool. Yeah, so that's one of the ways, like, this field is super exciting. There's many reasons why I practice in the field of pulmonary hypertension. The number one reason is because of the people I've met in the PH community. Like, early on, I went to conferences and met patients, and like, that's really what brought me into the field. However, like, it's super exciting. So for a rare disease, in this short period of time, we have over 14 FDA approved medications. More are coming down the pipeline. There are medications work in different ways, different pathways. And oftentimes we use multiple medications in one person because if one works this way and the other one works this way, you use them both together and there's a greater effect. And so not only have we developed over the years new medicines, but there have been clinical trials that have shown that the strategy of how we use those medicines impacts how people do. So way back in the day, you might say, and for certain conditions, you might go to your doctor and they'll say, try this medication. I'll see you in 6 months. If it's working, you stay on it. If it's not working, we'll switch it to a different medicine. And back in the day, it probably was like that in early days with many people who practice. But because pulmonary hypertension can progress and is chronic, the thought came, what if we treated it more like cancer, where we hit cancer? Well, this is before we had more targeted therapies.
Yeah.
But you would hit somebody with cancer really hard up front with multiple medications to slam their tumor and get it into submission. You didn't just dabble. Now we have targeted therapies, so it's like kind of different, exciting. And hopefully that'll be the next iteration with PH as well. Like, there are definitely parallels. So if one drug is good, maybe both drugs right at the beginning are better. And so we thought that in the field, many people, but then they did a clinical trial and they looked at one versus the other or both together. And sure enough, like, there was like a huge response, including patients with scleroderma. Like, they respond better to upfront, more aggressive therapy than just sort of trickling it out. And the other part that's been exciting is we now know through multiple registry publications, et cetera, that the sooner you make the diagnosis, or at least when people have milder symptoms, the more likely they are to respond, right? So, we try to really get into that early diagnosis campaign. It's a lot of what we do. It's why we screen people with scleroderma, in conjunction with you guys, to try and make that diagnosis. So there's a lot of exciting stuff. And I haven't even talked about, like, there's now new drugs, new pathways coming down the pipeline it's an exciting time.
I love it. It's really funny. I'm absolutely certain that depending on who we work with and what we know about the specialty that we, have in front of us, we can give words of hope versus words of total despair to a patient. Like, I bet there are some doctors out there that are not aware of all the advances of pulmonary hypertension, that don't even try treatment because they're like, forget it. And you've seen this?
Oh, 100%. A lot of
Yeah.
times come in, especially there's certain types of pulmonary hypertension, and depending on the knowledge. So, one of the things is that with a rare disease, if a person doesn't know, the doctor doesn't know, they just don't know about these things. It's hard to offer hope if you don't know that it exists, right?
Yeah.
And so sometimes people come in, and sometimes later than they should, just because it's always treat. One of the other, go ahead.
Sorry. No, I'm just thinking how, if there are patients out there that are listening to this, I think for me, one of the things that's extremely important is that you should get out of your visit with the doctor with hope. And if there is no hope, then maybe the doctor is not the right one for you. Or at least you can ask them, hey, do you have hope for me? And if they don't, maybe it's time to find another doctor. I'm not making a medical advice here. I just feel that the power of hope is so important, because then you have a plan, right? And when I hear you talk about all those different pathways, I mean, it's like I realize that I don't know, I know very, very little when it comes to pulmonary hypertension, when I look at all the things that and all of those new pathways and all of those new treatments that are coming. So it's exciting. I share your excitement as well when I hear this. Yeah.
Yeah, it's really cool. And one of the things, there's a couple of philosophies that I have in my clinic that center around hope. Like, there's a couple of things that we do in our pulmonary hypertension clinic. And also, like, we talk about on this organization that I work with, Team Phenomenal Hope, which is an appropriate name for your podcast. But one is that I feel like, when you go to the doctor, there's like this like, these are my symptoms, and then you talk at them, and then they talk at you.
Yeah.
Then you have the advice, and you get the medicine, and then you take the medicine. And that's not really how I run my practice. The way I see myself when I'm in my moment, when I'm like in my best self as a physician, is I see us as physicians walking alongside our patients.
Yeah.
So sometimes the pulmonary hypertension and the medicines is a small part of walking alongside. Like, you have to feel that you have an ally with you. And sometimes when you're, you'll tell people hard things to hear, but it's always with caring and compassion and this genuine desire to help people live their best lives. And that's I think how we as physicians can like manifest healing beyond just, here's your prescription, I'll see you in 6 months, right? It's more about having that presence. And the irony is, when you have that relationship, that therapeutic relationship, sometimes it goes both ways. Like, I feel like I get much more energy out of that dynamic just from having experienced like that half hour, whatever time period with that person, because it's like the greatest privilege we have. Like, who else gets to walk alongside people in just that way that we do as physicians? So that's, I think, that's that doctor-patient relationship that it's different. It's not necessarily a friendship. Like, it is, but it isn't. It's something truly unique to, I think, the role that we get to play in people's lives. So that's the approach that we take in our clinic. And I think that helps people do well. And it's beyond medications. We can talk about all the other stuff too. But yeah.
That's really nice. It reminds me of what Balint said. He was, I think, a psychiatrist, and he said that the physician offers himself as the treatment, that you're a medication by yourself. Like, the physician by themselves our treatments. And just the way that you approach the patient is extremely important.
When you have patients that come to you who have been told they have scleroderma, or people don't even know, that's also a rare disease. Few people understand, especially on the level you understand.
Yeah.
And so when they finally get to talk with you and you understand what they're going through, and you make words or help them make sense of it, that is something really, therapeutic in and of itself, beyond the prescription for a medication.
Absolutely. Just knowing that there's a plan, right? There's a plan, there is hope, and there is a pathway, right? There is like, this is the way, like, this is what we're going to do, and we're going to work with you. We're going to be alongside with you. I fully agree, right? Sort of a guide, like, hey, those are the studies, but you can take whatever path you want. Like, those are the studies. Yeah, I really like this. You mentioned Team Phenomenal Hope. Can you tell us more about this?
Oh, sure. Yeah, I'd love to. So Team Phenomenal Hope is a nonprofit. We started it 10 years ago.
Wow.
This is our 10th anniversary, but it's a nonprofit that we founded to bring endurance athletes to race in honor of, or in memory of, people who live with pulmonary hypertension. We started a program called Let Me Be Your Lungs. And that's where, so if I can run a marathon, or if I can run a 5K, many people who live with pulmonary hypertension have difficulty with that, may not be able to physically achieve that. So we pair them together with athletes, so that when people see our jersey, right, or whatever we're wearing, hat, whatever, and they say, what is Team Phenomenal? We say pulmonary hypertension. What is pulmonary hypertension? I can tell them who has pulmonary hypertension. I give them a human story about it.
Oh, nice.
And what I find in clinic as well as on Team PH is that when people live with a rare condition that very few people in the lay public know about, and a lot of what we do is raise awareness about this, of course, amongst general people, and you do something with them, you bond with them because you get it, whether you're an athlete, whether you're whatever, there's a sense of this caring between the athlete and the patient, or the doctor and the patient, like, hey, we got you. And vice versa. Like, again, it's a two-way street when you build these relationships. So we've gone on to fund research grants. We've gone on to fund a patient unmet needs program. And we have some teams in other countries, and we do educational programs and support groups. So the nonprofit's really taken off, and it's really exciting. People can find out more at teamphenomenalhope.org.
Yeah, I'll put this in the comments.
Thanks.
That's exciting. Happy anniversary. I didn't realize it was 10. I thought it was 9 or something, but it's exciting indeed. And you're doing so much for this team. You're constantly racing and creating. And it's like, every time we see posts from Dr. George, she's constantly on her bike and doing more. And it's just wonderful to watch all this energy shared, right? Like, it's really a loving energy that you're doing for you, but also for this community and for each of those patients. So I personally love stories, and we're coming towards the end of this episode, and I like hopeful story. Can you tell us a story of someone where maybe the patient really was scared and they came to you or to someone else, and you saw the difference, and suddenly their life was changed?
Okay, so yes, the hard part is choosing
Which one?
story. But I'll tell you what, because it's on the tip of my mind right now, and it's something we often see. Now, know that I'm giving you a story about a particular person. I keep it anonymous, of course, to respect privacy, but not everybody fits this story. So this is a story. So, but one we commonly see. So one of the other things that we do in our practice, not just me, but my colleagues, is we don't just talk about diagnosis, prescription, but we also talk about the foundation. What are the pillars of health? So the pillars being, are you getting sleep? Like, if you're not getting good sleep, how can you have a quality of life? Are you putting in good fuel into your body? Like, what's your nutritional situation like, How is your exercise? Are you moving? Are you expressing your love for life by at least some form of movement, right? And then the fourth is like, how are you doing spiritually, or mindfulness, or my mental health, however you want to label that, or socially with, social interaction. So these 4 pillars I think are really key. And so when we talk in clinic, in my initial, I try to get the information from people. And then when we talk about prescriptive, it's also about addressing these pillars of health. So in that essence, one of the areas that I'm strongly interested in is this concept of metabolic health. So it turns out that in certain forms of pulmonary hypertension, there is a higher prevalence of insulin resistance, type 2 diabetes, prediabetes, that sort of thing. And it turns out that those conditions are modifiable through how we approach nutrition, like the fuel source that we choose. And that's been shown, it's been published in papers, and now we're investigating it in some of the research we're doing. So this person that I'm describing, I had a person come to me, they live up in the mountains, spent their whole life building this home in retirement. And then over the years, started getting more shorter breath and fatigued and couldn't enjoy this beautiful mountain. So they came to clinic and like hopeless, right? Like this is something they spent, I mean, it's gorgeous. Like I saw pictures of it, it was gorgeous. And one of the things, living in Denver, I hate telling people you need to leave Colorado because I love it here. Like I do not want to, I have told people, I have recommended to very few people that you need to leave, but there are other ways to mitigate sometimes the problems we see with altitude. So anyway, this person needed to be on oxygen. We put him on oxygen. And then we worked, we did our National Jewish Evaluation, which is thorough. Like if we're going to find it, we leave no stone unturned. But it turned out that fortunately, this person did not have pulmonary arterial hypertension. And they did have like a little bit of, we call it HFpEF, or stiffness of the left side of the heart, and obesity and diabetes. And so I said, here's the deal. If you want to really do this, I'm going to show you a way. And we talked about things like cutting carbohydrates. We talked about intermittent fasting. I sort of presented all of these different ways that he could help improve his metabolism. And this person took our recommendations, but put it on steroids. Like I didn't say to do his method, but he took it and then really pushed.
Yeah.
And he had very severe diabetes, and within 3 months it was and the side effect, by the way, with this nutritional reversal using intermittent fasting and shifting his fuel source is he shed a ton of weight. It was falling off of him. And with that, over time, he's needed less and less oxygen. He will come off oxygen. He won't need it at his mountain home. And he's exercising, feeling great. And these people, when this happens, they often come off medications. They come in and I'm not prescribing. I'm oh, you're lightheaded now. Let's stop the blood pressure pill. These things can all be related. And so, so it's just super inspiring because it doesn't work for everybody. He was in that right place in his life where he was able to do that. 2 years prior to that, he wasn't in that place, right? And it's my job to walk alongside people and show them a potential path. And it's their job to decide if that's what they want to do and not judge. Hey, it could be different why don't we try this? If they want to try this, let's go off to the races, right? And if they don't, all right, we'll see what else we can do. We'll try to do something, but you know what I mean? And this guy, so that was a total reversal. And he's, he has this new lease on life because of the ability to enjoy life as he wants. So it's really cool. And that's not a unique situation. So people that do that lifestyle shift, whether it's all of a sudden doing an exercise program tailored to them, or again, metabolic health, shifting their nutrition, or sleeping well for the first time, attacking their insomnia, or attacking what are those things that are preventing them from doing that, right? So the mental spirit side. Once they do that, they have a different light behind their eyes when they come back.
I love it because you're basically, you started with all of those medications are available to us and we have more coming. And then the one story that has touched you enough to share with us is this story of the patient was empowered, and
Yeah.
he took upon himself to do the things that he thought would make him feel better, and it did.
Yeah.
I think it embodies exactly what I call the unabridged MD care, which is like this non-edited version of care where you're looking at the person fully, and you're, working with the patient, and you're just, not providing just the medication, but providing just the everything, every support there is from a physician's perspective, and the patient is empowered thanks to that, because you didn't necessarily have to talk about nutrition, right?
Right.
And here it is, like, not needing oxygen and being able to enjoy his retirement home. I mean,
Yeah.
cabin, or so. I mean, that's so powerful, so powerful. I mean, yeah, I could talk with you for hours. It's just such a pleasure. It always gives me energy, and every time I talk with you or I hear you talk, I just feel like, man, we should always be like Dr. George, right? Like, we should always be like Dr. George. Do you want to finish on what are you looking forward in the next year? For pulmonary hypertension, for your care, for
Yeah.
patients.
Yeah. So, yeah, thanks for asking. So certainly in the field, as I mentioned, there are all these clinical trials that are happening, new drugs coming down. And by the way, like, I prescribe medications. So you'll see doctors online, and there'll be people that say, you don't need these medicines for your pulmonary hypertension if you take this herb or what. Yeah,
Yeah.
you need them. Like, if you have PAH, frankly, you should take,
Yes, absolutely.
like, please. But beyond that, what else can we do? Like,
Yeah.
we can do so much more than just that. And I think that's so much more super exciting. So at National Jewish, one of my colleagues, Tim Lam, is starting a clinical trial looking at how to prescribe exercise for people with pulmonary hypertension. Like, we know there have been studies that show that exercise is good. By the way, back in the day, when it was early in the disease and people got diagnosed when they were sicker and more severe, we were scared to prescribe exercise. We might cause heart failure or cause them to pass out or worse, right? Now we know over time, and there's data to support it, that exercise is actually good. And but we don't know exactly the best type. Should we do interval training? Should it be endurance training? How long? How hard? How do we prescribe it?
Mm-hmm.
So we have methods that we do right now, but wouldn't it be so cool if we had data so that we knew exactly how to tailor and personalize, an exercise program to somebody? So he's going to look at that. Super exciting in PAH patients. And then my colleague, Darlene Kim, and I, we've gotten very interested in the role of metabolic health in patients with heart failure and PH, and how nutrition can really, like in the example I gave you, improve how we breathe. She just presented data in Athens, Greece at a conference, preliminary data from her clinical trial. And now we're going to take this in more and more patients and really study it, because so how does it work? If we can, like, improve people's metabolic health, how does it help the heart pump better? How does it, we've seen in her study that people feel better. So how does that work? And can we scale it up? Can we help more and more people that way? And like I said, the biggest part I get about that, like, you see all the numbers and you're like, it's like amazing, right? Oh my God, look at what you achieved. But the thing that's the biggest from seeing somebody who's gone through a transformative change is, like, what they radiate. And it's what you say, they're empowered, because, like, they did it. Like, sure, we might have introduced the concept, but I didn't put in the hard work. But they did, and it was hard work. It's not easy.
Yeah.
And they come in and they're just like, and that's what gets me the most excited. Like, the most excited about what I do is involving this sort of integrative technique, and now studying it with metabolic health in patients with PH and other forms of lung disease. That's
wonderful. Really, I think you embody perfectly what I think of unabridged MD. Like, you're just embody this perfect for me, like this vision of what a doctor should be and should be doing. And so it is such a pleasure to have had you here. I hope you can come back and tell us more. yeah, and it's thank you everyone for looking at this, and put some comments and like and subscribe and share and ask questions, because we bring people. And if you want to have Dr. Patty back, Dr. George, just let us know and we'll get her back, and you can even ask her more questions. She'd respond. She's on Twitter, and she's I will put all the information about the Team Phenomenal Hope. So again, thank you so much. I really appreciate.
Thanks, Isabel.
Thank you.